The screen, yeah, I don't want to see this.
No?
That one. And then just pull it up.
Oh, just to get it out of the way.
Yeah, there.
Okay. Hi, everybody. Thank you for coming over to the Center for Human Growth and Development. My name is Lindsay Mitchell, and I'm the assistant director here. Who's been here before? Oh, you guys are new. Good. Glad you found it. Glad maybe you found parking if you didn't walk over here. Yeah, end of the day is a good time to do meetings over here. So, so the Center for Human Growth and Development works to advance research related to child and adolescent health, behavior, and development, and we really try to provide a lot of services, programs, and opportunities to bring together folks across campus, medical school, health system, or medical school campus, and everywhere in between who are doing research related to this work, so we can all grow together. So I'm really excited to introduce you to Angela Capuano. Did I say your last name?
Capuano.
So she's here with us today as a clinical psychologist and board certified behavior analyst, doctoral and Leo lecturer out of the College of Education, Health and Human Services at the University of Michigan, Dearborn. So thanks for coming out today and making the drive to Ann Arbor. I'm going to also pass around this sign-in sheet, so if you had pre-registered, your name should be on here. If you could just check yourself off, and if not, you could just add your info to the back. That would be great. So I'll pass this around, and
take it away.
Take it away.
Okay. Well, first of all, I'm really excited to be here. I love my field, and I really love introducing new people to my field. So thank you for the opportunity to share more with all of you today. So to tell you, I don't know how to make it. Oh, I pushed page down. It's not. Oh, now it is. Okay. So to tell you a little bit more about myself, so like Lindsay said, I am a licensed clinical psychologist. I'm also a board certified behavior analyst. We'll talk more in a minute about what that means. And I work at the Dearborn campus, and I teach in our fairly new applied behavior analysis degree programs. We have a graduate and undergraduate programs. So we offer a full master's in applied behavior analysis, or we offer it as a certificate program, and there is an undergraduate certificate in ABA as well. I am also part of the Michigan LEND program. LEND is the Leadership in Neurodevelopmental Disorders. I'm the representative from the Dearborn campus. There are a number of people at the Ann Arbor campus that are involved in the LEND project as well. But it's a program to help produce leaders out of graduate students who want to work in the field of neurodevelopmental disorders. There's some things I hope you get out of this presentation here today. I am going to talk briefly about the certification and education pathways in applied behavior analysis, so you can learn how people become certified to provide this kind of therapy. I also really want to help share with you how broad the field of applied behavior analysis is. It's a lot more than just treatment for autism. And then I will also go over some new research developments in the field, talk about the research that myself and my colleagues are doing, and then talk about some future directions for that. Okay, so just to begin, I'm going to go over an overview, of the field here. But if you were to ask me, give me a very simple definition of what applied behavior analysis is, a simple one-sentence definition I could give you is, it's the science of changing socially significant behavior. And it is also characterized by data-based decision-making. So it is a field of therapy, but we focus on specific kinds of behaviors. And really a hallmark of the field is that we gather and analyze data as a means of making decisions in the field. I'm going to go through some of the history of the field. So the work that we do is largely based off of the work of B.F. Skinner. So if you've had Psych 101, that name should be familiar to you, right? That's the guy that worked with a lot of pigeons and rats. And what Skinner did was he developed the theory of operant conditioning. And much of the work we do in the field of ABA is based off of the theory of operant conditioning. So essentially, operant behaviors are willful, voluntary, conscious behaviors. And it is pretty amazing, but the work that Skinner did with pigeons and rats has a ton of applications to humans. So essentially what Skinner discovered is that there are universal principles of behavior. So what makes a rat press a lever, what makes a pigeon peck on a light, same principles as what, makes a human do the things that we do. So, what led to me choosing the parking spot that I chose when I came over here today, making sure I left with enough time to park, all of those things can be explained by Skinner's theory of operant conditioning. If you wanted to know when the field sort of officially began, now, the work of Skinner largely developed a lot of the field, and there is some, history before Skinner's work as well. But when the field of applied behavior analysis really declared itself as being this separate field was in 1968. And that was with the publication of the first Journal of Applied Behavior Analysis, which is still the flagship journal of the field. And the first article in that first journal was this one by Baer, Wolf, and Risley. And what they did was they defined 7 dimensions that define the field of applied behavior analysis. So for anything that you're doing to be considered ABA, it has to meet each of those 7 different dimensions. So here are the 7 different dimensions that define the field of ABA. So any treatment that we do has to meet all of those 7 dimensions. Any intervention, treatment center, we have to make sure we're hitting all of those. I'm going to elaborate on just 3 of those, and not coincidentally, those 3 are the ones that make up the term applied behavior analysis, because we are extremely particular about how we use our terms in ABA. So I'll explain to you why we even call the field applied behavior analysis. So the applied dimension of the field means that we focus on socially significant behaviors. And what that means is that the work that we do and the behaviors that we seek to change, we only change them if it's going to create some kind of importance to the individual that we are working with. So essentially, our behavior change programs have to benefit the individual that is actually receiving the services. So we don't change behaviors just because we can. We don't change them to make lives easier or more convenient for parents, caregivers, teachers, etc. We only change people's behaviors if it's going to improve the life or condition of the individual that we are working with. So some examples of socially significant behaviors would be to reduce self-injury, right? Reducing rates of self-injury, of course, produces a lot of benefit for that individual. Working on increasing communication skills is extremely socially significant because once somebody has better means of communication, now I've opened up a lot of new worlds to them. Now they can talk with more people, they can get their wants and needs met immediately. Like I've told many a toddler, I don't understand screaming and hitting, but I understand words, right? When they can tell you what they want, it's much easier for them to get their needs met. And social skills would definitely fall in the area of being socially significant as well. When we teach kids how to make eye contact, to greet others, to approach others, again, we've really opened up their world for them where they can have access to so many new sources of reinforcement. We do focus on behaviors in applied behavior analysis. So essentially behaviors are anything we say or do. Now, a common misconception actually of Skinner's theory of operant conditioning is that he ignored thoughts and feelings. That's not at all true. Thoughts and feelings are considered behaviors, no different from any outward observable behaviors. So they fall underneath all the same principles that operate your, running, kicking, jumping, same thing with your thinking, remembering, feeling emotions. All of those have the same principles that apply to them. The challenge with things like thoughts and behaviors, so things that are more private, is that they can't be readily seen and observed. So our challenge then in ABA, we can still study those behaviors and we can still do interventions that address them, but our challenge is we have to operationalize people's thoughts and feelings in some way. And that means that we have to take these private events or these abstract concepts and transform them in a way so that we can track and measure them. So for example, like let's say I wanted to study stress, right? Stress is a pretty abstract concept. In order to study that, I would have to find some kind of observable, measurable behavior that then leads back to stress. So if I wanted to study stress, I might want to study people's I could check their muscle tension, and that might give me an indication of what their stress is, or their heart rate, or their breathing rate, or maybe the responses on a scale of stress where they're trying to estimate their own levels of stress. So by doing that, I'm taking that abstract concept and I'm transforming it in a way where I can see, observe, and measure change. Because that's the only way that we know that anything has changed in ABA is if we see a change reflected in the data. So we don't just assume things have changed. We don't just assume our interventions have worked. We take data and track very carefully the behaviors that we are trying to change throughout our intervention and then analyze that data. So we have to create a data collection system for every client that we work with. And everything is very individually based too. So we learn a lot of different kinds of data collection methods. And then for each client that I work with, I'm trying to figure out what method of data collection is going to be best for this individual. We also don't assume that our data are valid either. We have methods that we use to check the quality of our data. That's not just for research studies. This is something that is done regularly in clinical practice too. We're always verifying and making sure that we have good quality data. Now bringing to the analysis portion. So we don't just gather data just for the sake of gathering data. We have to transform that data in some way to make it useful. So we analyze the data. And that means that we make data-based decisions in ABA. So all of our treatment decisions are based on our data. So concluding if a treatment plan has been effective is based on the data. Deciding if we need to change course of action and do a different intervention, again, it's based on the data. We don't assume things are working. We often do visual analysis through graphing our data. That is largely the analytical method that we use in the field. And because our change programs are so individually focused, the research design that is mostly used in ABA is single subject research design. So when you read studies, you're going to see a lot of methods like multiple baseline design, withdrawal reversal, alternating treatments design. That's largely how we do our data analysis in the field. Although there has been in the last few years more of a push to do larger group type studies, so that you will see in recent years more like randomized clinical trials being completed on our interventions, especially those that are designed to address very young children with autism. Okay, so I'm going to give you a brief example of some visual analysis of some data. So this is a client that I had worked with, and Jenna's not her real name, but we'll call her Jenna. She was actually referred to me for behavior problems. So Jenna had fetal alcohol syndrome, and she was recently adopted by some distant elderly relatives in her family. And she was referred to me because she was having a lot of behavior problems, you know, kicking and biting and spitting. But when I talked with her family, I also learned that she had a lot of difficulties with eating and gaining weight. Now, she could physically eat. There wasn't a problem with that, but she had a lot of difficulty with just having appetite. She didn't want to eat. When she ate teeny tiny little bits of food. And then her parents also told me in our first meeting that in 2 months' time, if she didn't gain any weight, she was going to be to have a feeding tube surgically inserted in her. So I told the parents, well, guess what? I can help you with that too. You know, that seems more pressing right now. Let's work on that. So we used behavioral methods to get her to eat more. Now, she was being closely followed by medicine, so she had a lot of medical intervention to try to gain weight. She was on appetite stimulant medication. She had her parents had calorie powder they could put on her food. But despite all that, in the last year, she had not gained any weight despite growing 2 inches too. So her BMI was really low. She was, 4 years old and wearing barely being able to wear toddler clothes. So I carefully tracked her daily caloric intake and the weight, how she gained weight too. So every week her parents would weigh her, and they would every day, every meal would track about how many calories she was eating. So this is the graph from the data that I tracked with her. Now you will see there are a lot of ups and downs. It was a hard fought battle with Jenna. She changed her preferences very quickly in what she wanted to eat. But but from start to finish, there was weight gain over time. And as you can see, it was slow and steady progress. There are times where you could see there are some pretty big dips where she did lose weight. During those times, she was ill. And when she was ill, she wouldn't eat at all. And then she would lose weight, and it would take her a couple of weeks to regain the weight that she had lost. But if we look at the visual analysis aspect of it, we could see from the beginning to the end of the program, she was able to gain weight. And the outcome of this is that the gastroenterologist was satisfied that she could gain weight without needing more invasive medical methods, so feeding tube was taken off the table. So just to go over briefly how the theory of operant conditioning works. So for every behavior, every operant behavior, there's a 3-term contingency. So there's an ABC to every unit of behavior. So the antecedent is simply what happens before a behavior occurs. Behavior is essentially anything we say or do. And consequence isn't used in any kind of pejorative sense in ABA. Consequence is simply whatever happens right after a behavior occurs. So it could be you're presented with something that you want. It could be you lose something that you want. Consequence just means whatever happens right after a behavior. And operant behaviors are largely controlled by the consequences. So what happens after behaviors. So a lot of our interventions then focus on the consequences of behavior. We do also have a lot of antecedent interventions. When we can, we try to prevent occurrences of unwanted behaviors, but we do a lot of consequence interventions. So to give you a very, very simple example, when I say sit, my dog then sits and I present it with a treat. So the antecedent is I give it the command, the behavior is the dog sits, the consequence is I reinforce the dog by giving it a treat. Therefore, next time I say sit, the dog is more likely to follow through and sit again. And what our job is doing, so for behavior analysts, our job is to first figure out what is the ABCs of the current behaviors that we're seeing. So a big assumption we make in this field is that behaviors all have a purpose, or we call it a function. So even if it's the most disruptive, an annoying problem behavior that you can imagine, if it's still around, it exists for a reason. The environment is supporting that behavior in some way. So my job is first, before I do any intervention, to figure out why is the environment supporting that? What is the current ABCs of that behavior? And then essentially the interventions I do, so I can't just change behaviors directly. Like let's say somebody is really depressed, I can't just say, okay, stop being depressed now, be happy now. Right? If only it were that simple. If that was simple, I wouldn't need a degree. But we don't change behaviors directly. We change them indirectly by altering what happens before and what happens after behaviors. So we alter the antecedents. We might do a lot of environmental modification. We change how we react once a behavior occurs, and therefore we can impact and change behaviors. And when you understand the ABCs, you can help you understand more about somebody else's behavior and also your own behavior. So I was thinking about this recently. How many of you are a fan of the new Duo two-factor login? Yeah, nobody likes it, right? Right? Every Monday morning when I go log in, I'm like, oh gosh, that thing again, right? I dread it. And if you look at it and you map it out through the ABCs, it makes sense, right? So before January, when I had the antecedent, I had the need to check my email. Behavior is I would just click one button, right? Because I could save all of my passwords. Then the consequence was within seconds, I was presented with my email. Now though, the antecedent is still the same. I have a need to check my email. The consequence is still the same. I still get access to my email, but what we've done is now there's more behaviors that are required. So we've upped the response effort that somebody has to show while still giving them the same amount of reinforcement, which means then if you're like me, you're just less likely to check your email, you delay it, or honestly, I just end up checking it on my phone because it's a lot easier. Right? And unfortunately, that can happen a lot of times when we're well-meaning when we're trying to design interventions for people that we're working with. Sometimes we make the right behavior too effortful to display, and it's just a lot easier to still get what you want by showing the problem behavior. So like a kid in the classroom, they can get teacher attention really fast by hitting somebody else, getting out of their seat, calling out of turn, as opposed to maybe showing more effort by sitting there, working on their work, being quiet for several minutes in a row, hoping that they might get noticed and get attention from the teacher. To talk about certifications in ABA and how somebody can pursue the educational pathway and how they can be certified to provide the therapy. It is a multi-tiered education certification system in the field. The good thing about all the certifications is that they are national certifications. So once you study and get certified in one place, you can work anywhere in the country, which is really nice. The entry-level educational certification just requires a high school diploma, and that's the registered behavior technician, and there are educational pathways all the way up through the doctoral level. Most people in the field function at that master's level. At the master's level, that's when clinicians can start to practice independently. So the master's level is kind of the backbone of the field. And then to look at how service delivery can look too, in many centers, service delivery takes this sort of tiered model as well, where the entry level folks, the registered behavior technicians, they play a very important role. They're often doing a lot of the face-to-face work with clients, where they would work typically one-on-one or one on a small group. And then their work is overseen by somebody with a higher level of certification. So somebody at the bachelor's or at the master's level. So in doing that, individuals at the master's level, they often oversee several clients' concurrent treatment. So at any one time, that BCBA, the master's level person, might be in charge of, let's say, 12 clients who are in the center at one time receiving therapy. Each kid, though, has one-to-one services being provided by the behavior technician level. So there's a lot of supervision, a lot of tiered service happening in the field. Now, if you've heard of ABA in the same sentence as autism, it's probably because of the work of Ivar Lovaas. So Lovaas published in 1987, he published this really seminal study on the use of ABA to treat young children with autism. Now, Lovaas was not the first, but he was one of the first researchers to use this technology of ABA in treating young children with autism. Because prior to this, ABA was largely a laboratory science. A lot of people were working with rats and pigeons and doing basic science and trying to understand the universal principles of behavior. Lovaas then published his study in 1987, and this was really landmark at the time because this is the first time he was showing that there could be improvement and hope for young children with autism. So in his study, he had a sample of young children. They were aged about 2 to 4 years, and they received intensive levels of treatment, so 40 hours a week of individual intensive behavior treatment. And after 2 years of intervention, he assessed them to see what changes were made, and he had control groups. But what he noticed is in the children that received intensive ABA after his period of at least 2 years, half of his sample were indistinguishable from their typically developing peers, meaning that those children who went through that intensive treatment were looking no different from their peers who never had autism. And those same kids then went on to complete first grade in mainstream school without any educational or extra supports. So they were able to achieve the same levels of testing and educational achievement as their typically developing peers. So this is when ABA really started to be like on the map and when people really started to pay a lot of attention to this field. So prior to this time, if you came into this, you've already heard of ABA, or if you've seen it being done, you've probably seen what's called discrete trial training. Discrete trial training is very popular because it is very effective, and it's very easy to train new clinicians in how to do discrete trial training. So by and large, if you're seeing ABA done, it's probably been with young kids with autism. And so now we call that kind of treatment early intensive behavioral intervention. Early meaning that it's applied to young kids, typically about starting from the time of diagnosis, which is usually around the age of 2, up until about maybe 6 years of age, you're going to see kids in intensive treatment. And intensive treatment still means about 25 to 40 hours a week of intervention. That is what has been shown through research to produce significant outcomes as far as significant gains in intellectual skills, communication skills, and adaptive skills. So discrete trial training is one form of early intensive behavioral intervention. So what's done in this type of intervention is you take any kind of skill and you break it down into the tiniest little parts that you can think of. You train each of those little parts again and again and again until the child achieves mastery of them. And then you keep adding on new and new skills, so getting harder and harder and harder in those skills. So it's a very fast pace of learning and is characterized by a lot of repetition. So a brief example here. So this is teacher-led. So the instructor would say, look at me. The behavior we're looking for is the child looks and makes eye contact, and then immediately the instructor provides a consequence in the form of reinforcement. Good job, high five, here's your point, here's your cracker, whatever the child is working for, and then right away you go into another trial. So it's a very high pace of learning. You get a lot of training done in a short amount of time. Other forms of early intensive behavioral intervention would be the Early Start Denver model. That is more of a naturalistic play-based intervention that's also been shown to be very effective. You're not going to see that very well represented around Michigan, although in the psychiatry department at this campus there is some research being done on that program. And another form of the early intensive intervention is called pivotal response training. So like I said, up to this time, if you've heard of ABA and you've seen it being done, you've probably seen one of these methods being done. What I really wanted to go into today, too, is show you how broad the field of applied behavior analysis is. So essentially, our technology is looking at understanding the activity of living organisms. So all of us have to do with living organisms in our daily lives, even if it's just ourselves that we're dealing with. So this technology can apply to a really wide range of topic areas. So this is really just a brief look at how broad the field can be, but there's a lot of overlap in the techniques of applied behavior analysis in the treatment of mental health disorders. So behavioral methods, anxiety disorders respond really well to behavioral methods of intervention. Using ABA is actually my favorite preferred way to treat obsessive compulsive disorder. There's a lot of overlap in the treatment of depression as well. When we start changing our activities, making ourselves do things, we do see elevated mood and better outcomes. And you can even use ABA to treat what you might think of as more severe kinds of mental health disorders. And actually there was a series of studies done in the 1960s where they used principles of ABA to treat catatonia in hospitalized patients with schizophrenia. So patients who had spent years not talking, not really reacting to any of the hospital staff over the course of several months and years, this one researcher got a guy to start speaking to him who hadn't, responded to anyone in years because they had pretty severe levels of catatonia. Essentially, ABA it's not just a therapy, it's a method of learning new things. It's a technology of learning. So there has been a method of ABA that has been developed for mainstream education. It's called direct instruction. And this is a method really just for typical regular education classrooms where there's methods for what you do with young kids all the way up through high school, and it's a developmental progression. And it became pretty popular in the 1970s, and research on it was very promising. Other researchers are looking at more large-scale interventions. So instead of just focusing on the individual, they're trying to apply this technology to the behavior of large groups of people. So a newer field that has emerged is called behavioral economics. That is the marriage of the fields of economics with applied behavior analysis. Now, previously when it started, it was looking at like a lot of decision-making research. So, and a lot of the research they call delay discounting. So would you rather have $10 now or wait an hour and get $20? And that's just the very, very basics of what they were looking at and, what are the factors that make people choose one over the other. But a lot of people recently are taking those ideas from behavioral economics and trying to understand and impact a bigger area of climate change. So when I was recently at a ABA conference, one talk I went to, these researchers were trying to develop an app that would reward people for driving at off-peak times. So therefore, they would spend less time in traffic idling and have fewer carbon emissions. Another amusing, actually it wasn't even study, but another amusing development that I've seen mentioned in studies and in the news is I don't know if you've seen them around here, but in like I know they do this in the London Tube, the men's restrooms in the London Tube, and in some international airports, the men's restrooms particularly. They're trying to help them be cleaner by changing the behavior of the men who are using the urinals. So they were actually they put up decals or stickers of often they use flies, and they put them strategically to try to help the men direct their urine into the urinal instead of all over the place. But actually, they found when they've done that, when they just put those stickers up, the restrooms are much cleaner than they were previously. So I would say that's socially significant change as well. There's, of course, huge overlap with animal training. Anybody that does animal training uses ABA, whether they really realize it or not. I mean, to have effective animal training, you're going to have to use applications of ABA. And I mean, not coincidentally, that's why I have a really well-trained dog. I mean, of course, I'm going to use my knowledge to benefit my own life, right? And there's a big overlap, too. There's a separate field of ABA called organizational behavior management. This is the application of ABA to the workplace. A little bit different from maybe traditional like industrial organizational psychology. It's not really about job selection and satisfaction. It's more of like how to get employees to stop calling off work, how to reduce accidents on the job, how to increase engagement on the job, get people to take responsibility, stop fighting. They're just trying to look at workplace behaviors and again, controlling large groups of people. An area, though, that I'm particularly interested in is using the techniques of ABA and helping with invasive procedures. So a lot of individuals with developmental disabilities see a lot of professionals, right? These kids see a lot of specialists. And often they have to have a lot of invasive procedures done just as part of treatment for the conditions that they have. And it is very challenging for a lot of individuals with developmental disabilities to cooperate with those procedures. So consequently, there's often sedatives that are used to help them comply, or often physical restraints are used. And it can be a very unpleasant, even traumatic experience for those individuals and for their families. So I'm very interested in using the techniques of ABA to help people comply better so that those restraints don't have to be used. So some examples of how some researchers have used these procedures to help with different kinds of areas. In one study, they taught some individuals with developmental disabilities to achieve really clean self-catheterization when that was required for their medical condition. Other researchers used ABA to train a sample of children with autism how to comply with getting an MRI. So again, without having to use any kind of restraint or anything, to get the kids to cooperate with, climbing up there, laying down, going in and holding still for the required amount of time. And then another study was looking at having an individual comply with needle pokes. So I'll go through that study in a little bit more detail. So the test subject was a teenage male who had autism, intellectual disability, and type 2 diabetes. He had a lot of fear of getting poked with a needle. He wouldn't do it himself, and he wouldn't allow the medical staff to do it either. So at the time the authors were called in to help with this individual, he had not allowed his blood to be drawn for 2 years. So his blood glucose had not been monitored for a period of 2 years. So obviously there's some very serious health implications for that, for this individual. So these researchers used, I'll talk briefly about some of the different methods that they used. So if you look at the experimental design, they used an AB withdrawal design, which is very, very commonly used in ABA. And so what they were measuring, so how they operationalized his cooperation was he had to hold his arm still on a specific spot on a table for a period of 10 seconds. The second he moved his arm away, then the trial was considered over and failed. So you could see here, they started with baseline where they asked him to lay his arm down, and then a nurse would approach him with the test lancet. And then you can see at first he was not complying at all. The second they approached him, he would move away. The procedure that they used, they used a couple different things, but they used actually a lot of antecedent intervention with this individual. They took a poster board and traced an outline of his arm and hand, and then they just laid that down on a table and asked him to lay his arm in that outline. And when they did that, you could see his rates of compliance or holding his arm there for 10 seconds immediately shut up. Over time, they did fade out that poster board where they made it, lighter and lighter. And then they also gradually got closer and closer to approaching him. And then when he did have a successful 10-second trial, they would reward him with a preferred food snack. So this took place over, you say 50 sessions, but the 50 sessions actually took place over 2 weeks of real time. So in 2 years previously, he had not allowed any needle pokes, and after 2 weeks, he was regularly allowing them. It's a little hard to see because everything's kind of squashed here, but at about session 30, there's an open circle. The open circles indicate when he held his arm still enough that they were able to actually draw blood and test his blood glucose. So that's about the point when he started to allow that. He kind of goes back and forth allowing it and not allowing it, but then at 2-month follow-up where they reassessed him, he was 100% of the time allowing the nurse to approach him and then draw blood in order to check his blood glucose. So again, they used, they systematically faded out that poster board and that outline and then got closer and closer to him until he was allowing them to be close enough to him and hold still long enough that they could actually check his blood glucose. And again, as soon as he moved out of the way, they would discontinue the trial and be done. They would do several trials within a day. That's why 50 sessions took only 2 weeks to accomplish, but they wanted him to cooperate. They didn't want him to have to be coerced or cajoled or held there or anything. It was entirely his choice to sit there and to allow it or not. But you can see it's pretty encouraging results here that, an outcome that hadn't been achieved in 2 years could be achieved in as little as 2 weeks. They did several sessions. I mean, they did 10 trials in a row, and they would do that 6 to 9 times a day. And thinking about that, and how to achieve better compliance with invasive procedures, so approaches in the field or techniques that we use, one of them is called systematic desensitization. So that's where you develop an individual hierarchy for somebody. So let's say whatever their feared situation is, so getting poked with a needle, that would be like the height of their hierarchy. And then you kind of work backwards from there and figure out, well, what's a much lower level thing I can expose this person to that they're going to tolerate? And then you gradually kind of take baby steps as far as getting harder and harder and harder or closer and closer to their eventual feared situation while teaching them how to relax and cope with it along the way. So you're training them how to handle that response by also reducing their anxiety. Other techniques that can be used are prompts and then fading those prompts, just like the study that was done with the needle exposure. We also do a lot of rehearsal, so we practice a lot of situations. I've done a lot of practice. Actually, I've done a lot of practice haircuts with kids. A lot of kids with autism really don't like getting their hair cut, so I've played barber many a time with kids. So we're doing rehearsal to get them used to that situation, so when they actually go through it, it's not as scary. And then, of course, using lots and lots of reinforcement. So pairing these things, these uncomfortable procedures, with things that they really want to get. So, if you sit here and you let me get close to you, then we'll let you look at the iPad for a few minutes. And of course, these are all very individualized, whatever that individual wants to work for. So now I'm going to briefly turn it over to my colleague, Peggy Ursey. She's a faculty in the nursing department. She's going to talk about the research that she is doing and that we are working on collaborating together.
Thank you, Angela. So my name is Peggy Ursey. I'm faculty within the undergraduate program in nursing, and I teach pediatrics, and I'm also a pediatric nurse practitioner. So last year, I was in the Interprofessional Leadership Fellows here at U of M, and I was teamed up with a dentist, a faculty member from kinesiology, and another nursing professor out of Flint, and we needed to come up with a project. So we decided to explore the LEND program, which Angela spoke to, and myself and Harneet Graywall from dentistry joined the Michigan LEND program. I joined as a trainee, she joined as a mentor, and that is where we met Angela and the rest of the team. So we had to come up with a project, and we were very interested in autism because Harneet is a pediatric dentist, and she trains residents who have a lot of disabilities on her Thursday clinic. And what we did is we had In My Shoes. It is in awareness and empathy training for health profession students. So we have to make it interprofessional based, and we had our topic of interest was focusing on autism, because we know that children, as Angela said, they have fears, and a lot of time when there's fears or if there's negative experiences, family members do not want to bring them into the clinic for necessary routine health promotion, and a lot of times we may see them end up in the ER when something becomes a crisis. So this started, we had our first training last March in 2018. We have our second training coming up in several weeks. And our team has changed a little bit as we completed the different fellowships. And we are sort of transitioning things where Angela is coming into our team and she's helping talk about the ABA aspect. And we also have someone in the genetics program here at U of M to put a twist on it that way. So the way that our program works is we try a multifaceted approach, and you can see from the pictures here, we use the virtual reality goggles to give the person a feel of what it is like to see and hear, the best that we can replicate what it might be like to experience autism. And we also have videos and interaction through Carly Fleischman on her programs that she does, Carly's Cafe. And so we also have some stories and excerpts that we share with the participants. We have kept our group small so far. In our first group, we had 12, and it consisted of dentistry, nursing, and we had some community members, some family members, and other interested persons as well. And so it was a 2-hour training. And after we had them sort of maybe feel like what it was like to get into character, we talked about how that applies to practice. So to make it interprofessional, the two groups had to learn about each other through roles, responsibilities, and we had them, try to figure out what the other group did. And then we started working on a case study together. And so it was like, what do we have? What do we need? Where do we need to go from here? And what resources do we need? So the first hour was experiencing autism. The second hour was going through this, and we figured out through small groups, working on this together and putting everything together at the end, we saw some of the same themes and patterns between making family empowered and to advocate, so to help with that. And we were always looking for a case manager, and what we have learned through the LEND program is that families are actually their own best case managers, and they rely on other families through listservs and forums to find out, do you know a dentist? Do you know a provider? Where can we go? I'm having this problem. Who can help me solve this? And so the main takeaways with this were the communication, the advocacy, and the education, and just the education, that resources that parents need, but also informing them of what is going to happen and what to expect. In our pre-evaluation and post-evaluation through Canvas surveys of our group on our pilot, we were looking at the social valuing, so the ISVS 9 for the interprofessional aspect, and also the Jefferson Scale of Empathy. We did not see a significant increase in empathy for our 2-hour training as a one-time episode. But what was interesting when we looked at qualitative comments, and that is the nursing students were undergraduate seniors, they saw this as more of a content or an instruction, which is what I would expect for my undergrad students. For the dental residents, they were actually looking at how to apply this to their practice. How can I change my office environment or my schedule to be more accommodating to a patient with autism? And what could we expect? And also, what can they put in place and coordinate with their school, or if they are in therapy, what can they do? And so we are looking at that, and we are going through this one more time, and hopefully going to offer it on a yearly basis. And we've been trying to improve it as we go along.
And you can stay up here, Peggy, so we're going to talk about this. But so, I mean, future directions or ideas where we want to go with this. So the In My Shoes program is a great program, but it's not ABA. We're trying to infuse more of the principles of applied behavior analysis in there. This next time when we do it again, pretty soon, actually in a few weeks, we're going to have a unit on applied behavior analysis and evidence-based practice so that the students are more exposed to that and they understand better what the treatment being offered in the community is. I'm very interested in working more to help children with autism comply with invasive procedures using the principles and techniques of ABA, but also in an interprofessional format. We are very interested in interprofessional education and applications of projects. That's where the future is, I think, where we want to go with a lot of the work that we're doing. And we are very interested in collaborating with other professionals who may have similar interests. So if that interests you at all, please contact myself or Peggy. And at this point, we will turn it over for questions and comments.
I'm curious,
Yeah.
have you done any dirty numbers as far as like, it almost seems like there's been an increase in children with autism. Any numbers as to like, as to what the increase has been recently as opposed to like maybe 10, 20 years ago?
Yeah.
Population
The current, everybody uses the statistics from the Centers for Disease Control because they take care of a lot of the incidence data. So right now the figures are 1 in 59 children will be diagnosed with autism. Boys outnumber girls 5 to 1. As far as what that looked like, I know when I was in college, which really wasn't that long ago, it was 1 in 10,000, and that was only 20 years ago. So it has incredibly increased. And researchers we don't know why. There's a lot of hypotheses out there as far as why that has increased. I mean, there is a lot more attention being paid to this, and now the pediatricians are, the American Academy of Pediatrics is recommending that pediatricians regularly screen, I think starting at the age of 6 months or a year. It's supposed to be a regular part of well-check visits now. So I think there's a lot more attention being paid and children are being caught sooner and sooner, which is great because what we know about intervention is the earlier we get intervention, the better, the far better the outcome. I mean, is there actual more autism? I don't know. We don't know. I don't think we know enough of that yet, but I know there are really large-scale longitudinal studies that are being carried out right now to follow families to help try to figure some of that out.
Do you know when that how long that regular screening has been in effect, or how long did that start? I mean, has it been something that's been going on for?
I want to say about 10 years, although I don't know exactly when that started, but I know that is, I want to say probably about 10 years now. It's been a regular thing.
Some of the children that we see in our practice in the psychiatric emergency services, some of them have yet to be diagnosed with autism.
Oh, wow.
And so they haven't really had any exposure to any kind of behavior therapy in any sense of the word. So any suggestions from our point of view, what we could do differently to maybe mitigate, use some mitigation strategies in terms of initial application to kind of get us through the initial situation of where we might be trying to change somebody's behavior?
Yeah, I mean, it's definitely harder when they're older and they haven't had any intervention. Because like I said, what we know in the research is that the earlier we start intervention, the greater the impact. And I mean, we're talking early. There's really great research being done out of the New England Center for Children, where they are looking at enrolling children as young as 18 months or even younger in intensive behavioral therapy, and as compared to children who start therapy at the age of 3, the ripe old age of 3. And when they follow them, over 2 years of intervention, the outcomes, it's not even comparable. The kids who started at 18 months far outperform the kids that started at age 3. So then you've got like a 10, 13-year-old who's had no special intervention. It's not hopeless. It's definitely not. I mean, you still will see benefit from behavioral therapy. It'd be a matter of getting them, in the right hands as soon as possible. But before we try an intervention in ABA, we first do an assessment. So we have to figure out, first, what are the ABCs of this person's behavior? How do they end up in the hospital? hospital, right? There's a lot of crisis behaviors going on, right? A lot of aggression usually. Often the goal for the kid with autism is to get everybody away from them, right? Just leave me alone already, right? So it takes a lot of careful observation and assessment, and that's where you need a trained behavioral therapist to do those assessments and figure out what is the function of this kid's behavior. Are they trying to get away from me? Are they trying to get access to something that they want? And can I teach them a more appropriate means of getting the things that they want? So yeah, there's no like real easy short answer I can give you for that.
And so is there a quick track to that, to ascertaining that from our point of view, in an emergent situation where this kid comes in and he's, behaviors are way out of whack and he's striking out and hitting people and things like that. Is there anything that you could suggest that, and I know I'm stretching a lot, but that we could do, in the emergent setting?
Some helpful, quick tips.
Sure. Well, I would say honestly, from what I've seen when I worked with them, I've worked with kids from young up to young adults, and I've been walloped a few times myself. Usually from my experience, the goal is just to everybody leave me alone and get away from me. So if that individual can be given like a safe space where they can decompress and maybe let some of the energy decrease, because especially if you're trying to communicate with somebody when they're on, when they're in panic crisis level, it's not going to be really effective because communication deficits are just a part of the diagnosis of autism. So we should expect that they're going to have difficulty communicating what they're thinking and feeling. And often that's hard for them. And then they're agitated and we're asking them for information that's hard for them to give us anyway. So usually getting quiet, safe space where they can kind of maybe work out the energy and decompress. And then when you see, then when we see the energy fall, then that would be more of the time to re-engage and approach.
So recognition of that energy, rise in energy is crucial.
Yes. And honestly, visual aids would be really helpful too, because again, a lot of individuals have difficulty communicating verbally, but kids might be able to point to, pictures or things that to sort of communicate what they want and need. But I would say usually the goal is get away from me. Usually aggression is only just to get people to leave them alone. It's not like a malicious, I want to hurt you kind of thing. Yes.
What do you think, so clearly you have to find motivators for these kiddos. What do you do with a kid who you're having a hard time finding a motivator for? Have you had times where you just haven't been able to find something that motivates them?
I've had times where it's been very challenging, yes. We have different kinds of assessments we do called preference assessments, where we systematically go through maybe stacks and stacks of different objects and again take data on which ones they seem interested in and which ones they approach. And I've had kids where we would literally get out like laundry baskets full of things. And this one, no, this one, no, this one, no. Only kids I've seen that reject absolutely everything are also having difficulty with sleeping and eating. So they're just super crabby all of the time. So sometimes we need to think beyond the immediate behavior problem. And is there, a sleeping or like a blood sugar issue going on? Because if there is, we're not going to get anywhere with therapy. We have to address those things first. But try a lot of things and then take data on it too. And also observe when they have free time, what do they do? What do they approach? Some kids will approach toys. Some kids are just going to sit in the corner and rock and flap, but we can use those in different ways. But a lot of observation too.
Do you use stimming as a...
No. We try to replace it with something more appropriate.
Yeah. What about just alone time then? So like if they're wanting alone time.
Yeah, that could be, right. That could be a reinforcer, right? You do something appropriate, do this work item with me, then you can have 2 minutes by yourself. If they like that movement of rocking and flapping, well, we might reinforce them with getting on a swing and swinging back and forth. Or I can, play Bring Around the Rosie with you. Yeah, we do something a little bit more socially appropriate. Yeah. Other questions?
But also, I'm just you look at the overall aspect of it, the behavior, if there's medicine involved, nutrition, and health stuff, that all plays a part of it, I'm sure.
Yeah, absolutely.
The medication, that's
It's tough. It can be hard to stay on top of that because I know the medication can change pretty frequently too. And then for the behavioral therapist to try to stay on top of that and how that's impacting the behavior can be kind of challenging. So when I can, I like to pair up with the prescriber and say, well, okay, whatever you're prescribing it to treat some kind of behavior, right? You're giving this med to, I don't know, reduce outbursts or aggression. Let me track it first, right? Let me get a baseline rate on this individual's behavior so I know, like, what is the frequency of their aggressive outbursts. Let's try the medication, and I'm going to keep taking data too, and then let's reevaluate in 2-3 weeks and see, have we made an actual impact on the behavior you were trying to medicate in the first place? Again, trying to be a little bit more systematic about it, and that's where that, interprofessional treatment can come from.
Well, for the board certified role in it.
Yeah, absolutely. You're not going to see those folks well represented right now, but I think you are seeing a little bit more of the board certified behavior analysts working in other kinds of settings. Again, yeah, if somebody's coming in from like a crisis or working on an inpatient unit, we want to get good detailed observations of what's their current behavior, what seems to be motivating them. Again, what's the function of their behavior, right? It could be a lot of private events that we can't observe, right? It could be, inner stimuli, right, that we may not be able to track very well, but we can also see, something's going on inside. I should see something happening on the outside too, to help carefully maybe track those things along with working with the prescribers. A lot of the work we do too is to help with not just complying with procedures, but complying with medications. Right? I mean, how often do people not follow the recommendations on not only taking the meds, but taking them as prescribed too, right? So a lot of the work we do is just helping other professionals, right? You know what to prescribe people, you know what treatment, what medication they need. The hard part is getting them to just follow it already. And that's where the BCBAs can come in and assist, is helping them follow these plans. There's a reason why you are keep forgetting every day to take your meds. There's a reason. Well, let me figure that out. Is it environmental manipulation that I need to do? Do you need to figure out a way for you to reinforce yourself when you do follow taking your medication the right way? Hopefully over time it would be self-reinforcing. I take it, I feel better. Right, that's been with a lot of I remember one teenager I was working with who he just would not take his anti-anxiety meds the way he needed to because he didn't believe they worked. Well, the one he took needed weeks to build up in his system. So we worked out an external reinforcement system. He can only get his computer, iPad time if he took his meds. Then after 6 weeks, he was like, oh, I really feel better when I take this. Like, yeah, no kidding. Right, but then he was motivated to take it on his own because he started to get the benefit from it. Other questions? Do people type them online too, or I don't know, because I can't see the chat or anything.
I don't think anybody.
Okay, well let me ask you guys. I'll ask you guys a question since you're sitting here and we have time. How do you think we just think about your own disciplines and where you're coming from, and you've learned a little bit about ABA. How do you see it as maybe working with some of the work that you're already doing? How do you think you could use these ideas or this technology?
I think that's why we're here today, actually, yeah. and because we've known that child and adolescent psychiatry has ABA therapists, and we want to look into psychiatric emergency services because so many times we have difficulties with placement of these kids and anywhere, and so we get them in our facility for long periods of time. And for us to change any behavior still as an emergent setting is very difficult, but how do we recognize, how do we bridge the gap until they do get placed in? So that's where we really see the need, and we're trying to investigate the potential of even looking to hire somebody for that role.
Yeah. Yeah, no, then there's just, I don't know, even 10 years ago, there was only 2 training programs in the state of Michigan. Now there's 10. And a lot of them have just come around in the last 5 years. So it's a really recent push in Michigan to have more board-certified behavior analysts. And now we actually, in the country, we rank number 10. So number 10 for the number of BCBAs in the state. So trying to find somebody shouldn't be too much of a challenge. What are some of your other thoughts on maybe how you could use what you've learned here in your practice?
I'm wondering if we should be in recording.
Mm-hmm.
That would help.
Yeah, absolutely. I mean, sometimes a lot of it is just, diagramming out why does this behavior exist in the first place, right? So our assumption is behaviors don't happen out of the blue. Something triggers it in the first place, and if it's still around, it's being supported by the environment in some way. And we need to figure out where is that support coming from, and can we eliminate that, or can we change it, or can we compete with it? Yes.
In your experience, do parents of these children usually have a good idea about what's causing the behavior?
Not usually. That's where a lot of the work is. I try to train them how to take their own ABC data. We do a lot of practice on that. I assign almost all of my clients to go home and do that, and then because I can't follow them, right? A lot of times I'm seeing them in an outpatient setting. I see them once a week, and I'm, just looking at the data sheets when they bring them back in, so I can figure out what's happened in the week that I haven't seen them. It's incredibly simple. It's a column that says antecedent, a column that says behavior, a column that says consequence. Sometimes I have people estimate like duration, especially if it's like outbursts or tantrums. I want an idea about how long it's taking. So I want to make sure I'm not only decreasing the frequency of the events, but also the duration of them too. Yeah, and as I'm reviewing that data, that's where I see a lot of patterns emerge, right? Because I'm trying to form a hypothesis. What is the function of this behavior? Because I can only match my intervention to the function. So I have to do my work first to figure out what's the function, and then I have to match my intervention to that, right? So there's no I always tell my students, there's no shortcuts. You can't go on Amazon and get the book of ABA interventions. It's not like here's the behavior plan for kicking, here's the behavior plan for spitting, right? Because it's all individual. I might have 5 different kids that all spit on other kids, but it might be for 5 different reasons.
When they come to our department, usually the family's in crisis, and a lot of times they're saying, he's really aggressive, and I don't know why, and he's hitting walls or, punching people.
Yeah.
But it's interesting that they have to go home and collect the data to try to figure it out.
Well, yeah, and I mean, once we're in crisis, we're just trying to keep everybody safe and alive, right? We're trying to find the precursors, right? Where is it like the lower level where we can still intervene with somebody? Because once we're on, level 5 emergency, we're just keeping people alive at that point. Right? There's not a whole lot of intervention that I do either. It's let's wait for the episode to pass and let's see what we can learn from this too. What are some triggers that were in place? Often there's environmental triggers, or for a lot of kids, it's, feeling a drop in their blood sugar, right? Meal times can be ripe times for behavior problems, right? I'm already a little bit off, I'm crabby, you told me I can't have my iPad, now I'm gonna strike you, and we're in all-out crisis.
That which kind of makes it difficult because we can get some of our patients we get up from a day to 7 days.
Yeah.
Multiple staff.
Yeah, you have them such short amount of time.
Yeah, so it's like this staff.
But you do have them 24 hours a day, so somebody could be observing and just seeing what are their normal day-to-day activities. What do they like to do when they're alone? What are their preferred, reinforcers, the preferred activities that they like? Can I get them to do something that I want them to do by giving them access to that thing that they like? Right, so that's the time we can maybe experiment their behaviors too, in a nice controlled setting too, where you have a little bit more support to keep people safe as opposed to like the outpatient setting. Right, where parents might be kind of hesitant to try different things because they don't know if they can control the situation if it goes bad. Yeah.
Are you considering translating your education at all for the emergency staff? What setting is it most appropriate?
It has been geared for, it's sort of been a convenience sample between our needs and I. So this year, we have a challenge getting nurse practitioner students to come because they're in clinical. So we have the convenience of the pediatric residents, and then we have access to undergraduate nursing students who are interested in coming on a volunteer basis as part of their clinical. This year we've invited social work students, and we have several responses from them. And then we have the LEND trainees in this particular cohort who are from audiology. And so we have several of them from different programs around the state that are going to be joining us And so we're expanding it. We're taking baby steps with this, trying to figure out where we're going, what are we doing.
I think we are interested in other disciplines if they're interested going
Yes.
through the training. Because the whole purpose is to build empathy for people with autism. We try to simulate what it might feel like. Okay, great.
Yes. I can give you my email and we can put you on the list and I can give you the dates and times of that. That'd be great.
Yeah, and we'd like more data too for our
Yes.
outcome measures too.
It is. We're just sort of building this. Like last year was our pilot, and we're expanding it a little bit more this year, and just seeing where it goes. Actually, so that was one of the reasons in my coming with Angela today was to see if anyone has ideas for where it may be helpful and some other things that we might consider. I'm interested in talking with you.
Okay, thanks. Yeah, and I'll pass out my copies of my cards. If you have any thoughts or questions after today, feel free to contact me. If you're interested in what I do or the professional program, please contact me. I know how to type.
Security a lot for UNH.
No, PISH students.
Thank you for having me.
That's really important.
Yeah, that's really important. Are you going to take